All things Neonatal Intensive Care Unit, caring for babies at the very edge of life, on this episode of All Things Women's Health. I'm an obstetrician gynecologist of some 30 years. I'm a husband, I'm a father, I'm a grandfather, a small business owner, I'm a Catholic. I'm a lot of things. I get called a lot of things. But on this show right now, I'm your host as we talk about really all things women's health. Everything from infertility to childbirth options, from menstrual issues to mammograms, homeschool curriculums to personal trainers. It doesn't matter. If it affects women and their health, it's on our agenda and always presented from an authentically Christian Catholic perspective. And our agenda today includes a very special guest, a neonatologist, Dr. James Cameron. That's a specialty I'll bet most viewers have probably never encountered. I personally hope you never encounter that specialty, but we're going to learn a lot more about neonatology and the unit in which those babies are cared for. So, Dr. Cameron, James, thank you for coming.
Thank you for having me.
Yeah, well, it's great to have you here. Thanks for spending some time with us. So let's start easily with just a little bit about you.
So, as you said, I'm a neonatologist, and I was born in Indiana, spent my early years in Illinois on the south side of Chicago, and through fate and Dad getting a job at General Motors and transferring to the plant here, I moved here when I was in high school. Finished up high school here, did my undergraduate here back when it was Indiana Purdue at Fort Wayne.
Yeah.
I ended up doing my medical school training over at IU in Indianapolis for my 4 years. I ended up doing my residency at Wake Forest Baptist Medical Center, and it was a wonderful place to do a pediatric residency because while there were fellows there, they were not, overbearing. And so the residents got a lot of experience in everything that they did. In neonatology, we did a lot of neonatology.
Right.
And because of that, that certainly drove a passion for that. And then due to some things that happened in my family, there was a lot of passion there as well and understanding with the families that were in the NICU and what they were going through. And so that led to me deciding to do a fellowship in neonatology. I went to Cincinnati Children's Hospital and did my 3-year fellowship there, and then started out my early career at St. Vincent in Indianapolis in their level 4 NICU. Got a lot of great experience working there for 3 years, and then the opportunity to move back to Fort Wayne.
Full circle.
Yeah, where my family was, where my wife's family is, and I've been here for 17, 18 years now.
Wow. Now, we have our lingo in medicine, as we all know, but we should probably back up. So all physicians go to medical school, and then now all physicians do a residency in some specialty or another, be it family medicine or OBGYN or orthopedics, in your case, pediatrics.
Yes.
But then we use the word fellowship, which is not all that intuitive. So this is training after residency. Maybe explain that just a little.
So everybody that does a residency program is going to go through a process after they complete their training and board certification. So you have to pass a test set by your specific board to say that you are adequate to serve in that role as a general pediatrician, a family medicine doctor, an OBGYN.
Sure.
After that training, you're then qualified to apply for fellowships, and that is additional training in a small niche of that specialty. So for pediatrics, you can do one in infectious disease. You can do it in nephrology or kidney disease.
Yeah.
You can any number
There's
of
lots
things.
of avenues.
For me, I chose babies. They don't really talk back a whole bunch. They can't punch as hard as the older kids can in the clinic, so I thought that was a safe place to go. And so fellowships are going to range in duration of, depending on which area you're going into, but just about all of the pediatric fellowships are 3 years.
Yeah.
And so there's a year or more of training. And then in addition to that, during your training, you're doing at least 2 years of research as well.
Wow. And so, and you mentioned you did your fellowship at Cincinnati Children's.
Correct.
This is not a plug for Cincinnati Children's, but that's not just any institution. It's world famous. In our area, it's most, I guess, famous for fetal surgery, operating on babies that are still in mom's uteruses. but it's famous for a lot of things. So that must have really been exciting.
The opportunity to do my fellowship at Cincinnati was wonderful. I
Wow.
was offered positions at the places that I applied to. Um, One was at Wake Forest, but the opportunity to come a little bit closer to the Midwest
Oh, sure.
was a little too enticing to pass up.
Yeah.
And then the other choices were something a little bit more local, and then
Yeah.
Cincinnati Children's. And Cincinnati Children's, obviously, you're going to get the best training in the world there.
Wow.
So I certainly took that
Well, we're
opportunity.
lucky to have you here in northern Indiana.
Appreciate that.
So I remember in a galaxy far, far away, a long time ago, when I was an intern in OBGYN at the University of Virginia, we did a month in the Neonatal Intensive Care Unit. And in medicine, we love our abbreviations. That's NICU, and we say NICU, which has a kind of a weird sound. But we did a month in the NICU. In fact, I think that's right where I met my wife, who was a nurse there. But I remember it being the most horrible month of my life. All I remember was I was afraid to touch anything, and there were alarms going off everywhere, and I'd go home most days with a headache. But, talk to viewers, what exactly is an NICU or a NICU?
It's neonatal intensive care, and it can range anywhere from a child that is truly critically ill without the technology that's being offered to it, it won't survive.
Yeah,
Or a baby that simply can't survive outside of the NICU, needs the intense monitoring, frequent nursing care, and then any medicine or additional care that isn't going to be intuitive to a caregiver. A late preterm infant is a good example. So some babies that are born at 35 weeks gestation are doing well. They don't need to be in the intensive care nursery. Others, their brain may still be immature enough that they don't eat well. They don't always remember to breathe. We call it apnea of prematurity. Their thermal regulation or their ability to maintain their temperature may be off, or they may simply have an infection and have problems with breathing or just have immature lungs.
wow.
And so those babies oftentimes will need just that little bit of extra monitoring that you can't really offer in a regular newborn nursery.
So that's really a pretty comprehensive list of reasons, what some people might call near term, sort of 35 in that area, less than 37, less than 36, but particularly less than 35, right, that they're likely to need. But they tend to do well, but they tend to need some help.
Yeah, so our late preterm infants, that goes all the way up to 36 weeks and 6 days. Those babies are, for the reason that I mentioned,
Yeah.
a little bit higher risk. Even if they go to the nursery, they're going to be watched a little bit more closely
Yeah.
by their pediatrician. They're not going to be the one that you send home in 12 hours. They're probably not going to go home in 24 hours if it were me taking care of them.
Yeah.
Because we are fairly cautious with them because they may start to exhibit those signs of prematurity
Yeah.
towards the end of that first day of life.
And I think it's important to point out, this seems to come up in our prenatal care visits a lot. It's not the size of the baby, it's the number of weeks. Or as a mentor of mine used to say, it's not the size of the bun, it's how long it's been in the oven. But I think a lot of times people are confused. They think, well, my baby was born at 35 weeks, but he was 7 pounds, 2 ounces. That's a normal sized baby. He'll be fine. But it's not the size, is it?
Sometimes the largest babies are the most challenging.
Yeah.
There's several different reasons, whether it's a complication that comes up during delivery because they're fairly large and it becomes a difficult delivery,
Sure.
or just because there was some insulin resistance or mom was a gestational diabetic. And then we have the problems I have to watch for with those babies afterwards with blood sugars, making sure their blood sugars are okay.
Yeah.
Oftentimes they're absolutely horrible eaters initially. And think about it. These are babies that are large for their gestation. And so their
Yeah.
brain is saying, I don't need to eat anything.
Right.
And trying to figure out what the right amount that they need to allow them to gain appropriate weight, and still make sure that we're not sending them home
Yeah.
to fail to thrive and put their development at risk is really the biggest challenge that we have. There aren't any growth charts for these infants of diabetic mothers.
It's really interesting because we love fat babies in America, right? I mean, that's,
They're cute.
the Gerber baby, for years ago, I remember it was a fat baby, probably overweight baby. But I mean, I think you do a great job of pointing out those big babies may be the ones that have the trouble for all of those reasons that you mentioned. So it can be, it's not necessarily intuitive if a family thinks just because he's big, he's fine. Maybe
Right.
just the opposite, right?
Yeah. And sometimes these babies also have respiratory problems when they're big. The infants of diabetic mothers, one of the
Mm.
things that we watch for is surfactant deficiency in them. They can certainly have, that typical preterm disease, respiratory distress syndrome, or immature lungs
Yeah.
in a baby that is near term or term even.
So talk more about that word, surfactant. That's not a common word that gets used a lot. What do you mean, surfactant deficiency?
So, in terms of lung physiology, surfactant is a chemical that is put out by the lung tissue into the airway, and it allows our lungs to be able to open up when we take a breath. And then as we exhale and breathe the air out, it lets the air spaces close up, but not completely.
Uh,
And so, as the lungs open, the surfactant gets a little bit further, the proteins get further apart, and it gets harder and harder for them to open up so that you don't really pop your air sacs.
yeah.
And then as you breathe out, they get closer, and it causes the air sacs to say, "No, I don't want to get any closer together."
Uh,
And so it's a really amazing molecule in terms of how it functions to let us breathe easily. Without that, it's like trying to pull two wet pieces of glass apart.
wow. And babies of moms who have gestational diabetes or diabetes caused by pregnancy, those babies have a tendency to be deficient in that critical component, right?
They have a higher risk for that, yes.
Yeah. And then how would you know? What's the sign that a baby may have that problem?
So a baby that's delivered after a normal labor process, other than being an infant of a diabetic mother, and they come out, their oxygen levels are good, they're breathing comfortably, they're not breathing fast. Those babies
Yeah,
probably aren't going to have surfactant deficiency, or at least something that's not severe enough that we're going to have to get involved.
sure.
But if they come out and over the course of that first 4 hours, 12 hours, they start, having a little bit faster breathing rate. They start working harder, and you notice that their chest is sucking in with
Uh,
each breath. If you check their oxygen saturations may be low,
mm,
and then that's a sign that they either could have pneumonia. There could be something else from certainly a heart standpoint, although those are oftentimes very comfortable babies, or they have some surfactant deficiency
yeah.
that is starting to become more and more obvious.
So a baby, if we're just thinking sort of hypothetically, a child that starts to show signs of not not necessarily doing well from a respiratory standpoint, and we see this, babies that are clearly working hard to breathe. They're doing fine, but they're working too hard, and you get involved. What kind of interventions do you commonly do for those children?
So if it's in the delivery room, our goal is to try and get the baby to transition. If you can get the lungs, those tiny air sacs or alveoli to open up and get the blood flowing into them, you can avoid a lot of problems, whether it's, having the baby want to pretend or have the physiology continue to behave like they're inside mom, basically acting like there's still a placenta there getting oxygen into it when it's no
It's
longer
no
there.
longer there. Yeah.
Doesn't work very well for the baby.
Yeah.
Or from the standpoint of just opening up the air sacs, clearing that fluid out, whether it's going out through the mouth and they cough
Mm,
it out, or um, during normal labor process, a lot of that fluid is moving back from the alveoli or the air, what's going to be the future
yeah.
airspace, into the vasculature, into the lymphatics, and moving
Yeah.
out of what's going to be the future airspace. And so we really try to promote that, whether it's with some gentle chest physiotherapy. It sounds like a massage where we're just beating on their chest a little
Uh-huh.
bit like that.
Yeah.
Um, Sometimes we're giving them some mask CPAP, continuous positive airway pressure, similar to what adults use for sleep apnea.
Yeah.
But we use that a gentle amount of just constant pressure. That's enough to allow those air sacs to open up. We call it recruitment. So
Mhm.
opening up those air sacs. And as they open up, the blood starts to flow into those air sacs better. You get oxygen that the baby's breathing in is getting into the bloodstream. The waste gas, carbon dioxide, is getting into the alveoli
Uh,
and coming out. And you have a baby that's hopefully going to transition well.
yeah.
We like those babies to stay warm, so we oftentimes will do that over at the warmer.
Mm.
Certainly, we want to do our best to keep mom and baby skin to skin, but when we need to focus on the baby, we want to make sure that we can get to the baby and be able to assess the baby
Yeah.
completely so that we're
Now,
not missing something.
you've used a phrase that we use a lot, and I think we take it for granted, transition.
Mhm.
And I don't know why, but lately it just occurs to me, maybe it's my age, of how amazing it is when a baby takes its first breath. But it's worth pointing out their lungs are full of water, right? They've been full of water since they were formed. And in an instant, they go from not breathing to becoming air breathers. And we call that transition because it doesn't happen within an instant. There's some stuff that has to take place. But when we say transition, we mean that sort of gradual move from being a scuba underwater, using the placenta to breathe, to actually breathing air as we breathe now without a placenta. And that transition usually goes well, but sometimes it doesn't, right?
Right.
Yeah. You also mentioned if those babies don't have pneumonia. And I think viewers find that interesting probably because you think pneumonia, you think, I was out in the rain, I was next to a bunch of sick people, I got pneumonia. How does an infant get pneumonia?
Well, think about where the uterus sits. It sits on top of the vagina.
I
Which
wonder
is
what you were
right.
struggling with there. Yeah.
Think about where the uterus is. It's right next to the vagina.
Yeah.
And that's right next to the rectum.
Yeah.
And so there's a lot of bacteria there, whether it's group B strep, whether it's E. coli. Those are our two most common organisms that we see in early onset sepsis.
And those are normal organisms for the mother.
Yeah,
It's
they
not as though she
absolutely
has an infection. That's just bacteria that live there. We all harbor those bacteria.
Right.
But that's where a child passing through that region could acquire a bacteria that causes a pneumonia.
Sure, and it's not even just passing through. A baby that's delivered by C-section can,
Sure.
whether the membranes are ruptured or whether they're intact. Bacteria have been shown to easily translocate or cross the amniotic membranes into the amniotic fluid, and then the baby can be breathing that into the lungs because the babies are still taking breaths, obviously. And if they're breathing that infected amniotic fluid in, there's still going to be bacteria that are getting into the lungs, and that risk just continues to go up the longer either mom's ruptured for, or certainly if she's having a prolonged labor and the membranes are just exposed to the vaginal flora.
It's more opportunity for those bacteria to make their way in, and then more opportunity for the baby to encounter them.
Yeah.
And then how do you treat an infant with pneumonia?
Antibiotics and support.
Yeah.
So it's not just supporting the killing of the bacteria, and because the baby's immune system is truly just what the mom has passed to it during that last trimester in terms of antibodies. They have a white blood cell system that's gonna try and fight it off, but it's not really all that effective. And so a baby left to its own is not going to be very successful if it's got an infection and can easily be overwhelmed by that.
Wow. So you mentioned those three magic letters that we talk in obstetrics about a lot, G, B, and S, or group beta strep. And I mean, it's a topic probably worthy of its own podcast episode, I suppose. But, we talk about it in the obstetrical world with our patients all the time. I can't remember when. It's been more than a decade ago when the CDC recommended testing all mothers. I forgot when that change happened. It could have been 2 decades ago. Because there was a time when it wasn't recommended to test. And now it's recommended to do the Q-tip swab and test all moms to see if they happen to have group beta strep as part of their normal bacteria. And then if they do, or if they're GBS positive, as we say, then it's recommended to treat those moms in labor. But we're not really treating the mom, are we? We're treating the baby in a preventative way because it goes from the mom to the baby. But, talk from your perspective. So when I think GBS, I'm thinking baby's still inside. But then I hand this baby to you. What's the world of GBS look like to a neonatologist?
When I think of group B strep, GBBS, I think back to college really in microbiology, and we plated beta hemolytic organisms on blood agar. So these beta hemolytic organisms would break down the red blood cells and the hemoglobin, and it would change the color of that agar. And it just made you realize how potent that was as essentially a toxin in the body. And so then you think about what this organism has the potential to do as it is, the bacteria are, turning over, they're releasing toxins into the bloodstream. E. coli is notorious for that as well.
So when you think of GBS as a neonatologist and I hand you a child and you think this baby has GBS, what's that look like? What happens? And what are the issues that you're thinking of and considering when you're treating those children?
Yeah, so we have three different ways when we're looking at early onset sepsis in terms of determining whether or not we want to treat them or watch them, either getting frequent vital signs and frequent examinations, or if we are just good, this baby's not at risk, we don't need to worry about it.
Yeah.
So if a mom is Group B strep positive, that's going to be certainly a big red flag for us to be
Yeah.
aware that there's a potential problem. Moms that are Group B strep positive traditionally now will get intrapartum antibiotic prophylaxis with penicillin, ampicillin, cefazolin.
Yeah.
And the reason for that is because it very quickly can go from the mom's bloodstream, and within 15 minutes, it's able to be found in the umbilical cord, so the baby's bloodstream. And within 45 minutes to an hour, it's actually in the amniotic fluid.
Wow.
And so knowing that the mom got treatment, ideally 2 doses greater than 4 hours prior to delivery, tells us that the baby is at lower risk, not zero risk, but lower risk for developing that early onset sepsis as a result of Group B strep. It may be effective at reducing the risk of E. coli. I don't know if there's any data to support that. A lot of E. coli now is resistant to penicillin. Probably more than 50% of the ones that we see are resistant to penicillin. So it doesn't really help out a whole
But it helps
bunch
with the
that.
GBS.
But for Group B strep, absolutely, it's going to help.
And then what do you do, if anything, to a child born to a positive mom that received her antibiotics in labor? Now this child is born. Is there anything to do other than just to be cognizant of problems could occur?
Yeah, so I think that's really it. So long as the mom wasn't febrile, so long as the membranes weren't ruptured for an extended period of time, 18 hours is that traditional cutoff. It's a number that they use, which at that threshold, the risks seem to go up.
Yeah.
But really, when we put that data into the sepsis calculator, which is one of those three methods we were talking about, it adds, depending on how long it's ruptured for, adds to that risk stratification. So if we're ruptured for 18 hours, that's not as bad as if we were ruptured for 36 hours. Just like if mom has a normal temperature in labor, that baby's not as at much risk as a mom who has a temperature of 100 versus a mom that has a temperature of 101 versus 104. And that mom that has that temperature of 104, in almost all of those cases, we're going to really have a hard time convincing ourselves that this baby shouldn't have an extensive evaluation and probably even be treated.
And treatment would be
possible
putting on IV
sepsis.
antibiotics. Yeah. And then what do? They clinically, they look normal and healthy. You put them on IV antibiotics and sort of stare at them for a while, right?
Yeah, it certainly seems that way to the families.
Right.
Because the baby looks well, especially if they've had, 3, 4 babies and they've all looked good and they've all looked like this. The problem is that these babies, if they didn't get antibiotics, and we know that the mom's Group B strep positive, if we know that the mom's Group B strep negative, that doesn't eliminate the risk for the baby developing this. So I'll talk to you about that in a second.
Yeah.
But the baby still needs to be watched because the antibiotics are good at reducing the risk, but it's not a foolproof method. So we'll watch the baby. We'll check the vital signs. We'll make sure the baby's breathing well. We send off a blood culture when the baby comes to the NICU. That lets us know if there's bacteria that are going to be growing in the bloodstream at the time. It's not a great sample. It's not foolproof because for adult blood cultures, they're drawing like 3 to 5 milliliters of blood.
Yeah.
For a newborn, we're drawing half an ml to 1 ml of blood and putting into a culture bottle. And so your sample is not quite as effective at detecting sepsis. But we also look at the clinical symptoms, look at how the baby's doing.
Yeah.
And if the baby's looking good, the baby is not having difficulty breathing, the labs are reassuring, then the baby typically is able to have the antibiotics stopped. Depending on where you are, it can be anywhere from 24, 36, 48 hours. And we also look at the placenta, and the placenta is one of those things that really leaves us in a little bit of a quandary because when the baby's attached to it. It's the largest fetal organ.
Yeah.
And so if we see that the placenta has signs of chorioamnionitis,
An infection of the
inflammation or
placenta. Yeah.
infection
Mm-hmm.
in the placenta, then it makes us worried that maybe there's something that could be going on inside the baby now as well, because the baby was attached to this organ right up to the point that it delivered, and then the cord's cut and the placenta's gone.
Right.
But if there was evidence that that infection was traveling up the umbilical cord, that gets us a little bit more anxious. And certainly, we can't ever say that there wasn't bacteria that was coming from the placenta into the baby. And so that's why we're always a little gun shy when we see the word chorio or another word, sinusitis, which is the umbilical cord, or vasculitis, the blood vessels having.
Even if the child looks good, you're worried because the placenta looked infected.
Yeah.
And you wonder, is the baby just not sick yet? Yeah.
Yeah.
Interesting.
And so those are the things that, keep us up at night. Most people will be like, oh, the baby will be fine. Most of the time, you're right, the baby's going to be fine. But there's still that risk that, the baby is going to develop an infection that can be overwhelming. And the problem with that is that can happen very quickly. A baby can look wonderful at delivery. No problems breathing, no problems with their temperature. It's eating well, it's latching on and breastfeeding well. Around 5-6 hours of life, everybody's settling in, getting used to the fact that the baby's doing well.
Yeah.
Baby's down in the bassinet. Mom takes a nap, wakes up, and the baby's breathing a little bit more difficult. Is that abnormal? Is it normal? It's hard to say. It's not bad enough. And it can just sneak up on you, but it doesn't sneak up on you over the course of days. It sneaks up on you over the course of hours.
Now, when you say that, you mean the disease process.
The disease process, yeah. So
that's why it's called
sepsis.
rapid onset GBS problems, right?
It can be, yes. Yeah. And so I would say anyone in my field has seen a baby that's come in well-looking, well-appearing, and came to us because at 6 hours, 12 hours, 24 hours of life didn't look healthy anymore. And, sometimes at that point, they've already been so overwhelmed by the bacteria that it's difficult, if not, in some cases, impossible to help that baby survive.
Wow. Now, before we started recording, you shared some, I thought, really fascinating numbers. I wish I could commit them to memory, but I didn't.
Me too.
But I'll try this time. But you were talking about percentages and numbers of children with GBS. Give that perspective again, because I thought that was really fascinating.
Yeah, so there was one study that looked at, in their single center over the course of, I think it was about a decade, 17 newborns that had tested positive for group B strep. Of those, 14 of the 17 were born to moms that were group B strep negative.
Yeah.
And so that just goes to say, even though we're testing all of our moms for group B strep, we can't just
It's not
assume
perfect. Yeah.
that symptom that baby's having is not because the baby's got an infection.
And I think we learned a lot of that during the COVID pandemic. You're sick, you get a COVID test, it's negative. You get sicker, you go back and test, it's positive. Right. The testing is not perfect. So the swab we do for group beta strep, maybe we just missed it. But we called her GBS negative, and now 14 of those 17 were from negative moms.
Which means that 3 of the 17 were from moms that were group B strep positive and presumably were treated because they knew they were group B strep positive.
Yeah.
And so even the treatment, even though you're getting those levels up to, therapeutic levels inside the baby, inside the amniotic fluid, it's not necessarily always enough to destroy the bacteria.
Yeah. And then, listening to that, you could become really paranoid and think every baby is just going to crump at 6 hours. Yeah. Yeah, that's your job, is to be paranoid for baby's sake. But it must be that many babies are GBS positive and they do just fine. They somehow managed, it wasn't an infection, it was just there, or they fought it off successfully. But your job is to catch those that don't do that, and it can be very serious when it happens, can it?
Right, it definitely can. From the point where their heart isn't able to work properly, their body can't process energy adequately. They develop what we call metabolic acidosis, and their pH, normally we want them to be sitting close to 7.4. they're less than 7.
Yeah.
And if you're less than 7 for any amount of time, your chances of survival are very low at that
Just
point.
like with adults who
Just like
become
with
septic
adults.
and get what we call multi-system organ failure, the infants do the same thing and don't survive.
Yeah.
So, I mean, it's interesting. I think a lot of our parents are thinking, gosh, you want me to treat this theoretical thing that I'm just not convinced maybe that it's something to do or something necessary to do. And then I think a lot of parents have questions about, is there a downside to me getting the penicillin or the ampicillin in labor? Is there anything that I'm going to harm with the baby? Is there a risk to the baby of treatment? How do you respond to that?
Certainly, you can alter the normal flora of somebody by giving them antibiotics. We know that in the lactobacillus, the bifidobacteria that we think about in the normal healthy newborn gut from a breastfed baby,
Yeah.
they get killed very easily with a single dose of antibiotics. You keep breastfeeding them, you keep giving them those probiotics and the prebiotics. The prebiotics are the milk oligosaccharides that are present there that are not just nutritious for the baby, they're nutritious for the bacteria that are in the gut.
The good
healthy
bacteria, yeah.
Bacteria.
Yeah.
And so continuing to breastfeed those babies when they're healthier is going to help restore those bacteria to the normal, what we would
Sure.
consider normal healthy flora. But, certainly there's risk of babies when you're over-treating. You're going to have more babies that will, develop yeast infections or thrush.
Sure.
But what I would say is that we're not treating every mom with antibiotics. If we did that, we would probably see complications that come up from thrush. But we typically aren't going to see that.
Yeah.
The complication will have is their tongue will be coated. They're going to
Sure.
be cranky. They're not going to eat well. In severe cases, they can even develop esophagitis. But that's treatable. It's
Yeah.
easier to treat than the baby that's going to die in 6 hours, 12 hours from Group B strep. So I always go with the risk versus the benefit.
Right.
The risk is having a baby born to a mom that we know is Group B strep positive has that high risk for developing an infection if the mom doesn't have that prophylaxis versus the possibility of the baby developing thrush.
Right.
And not all babies, we would have a huge amount of thrush out there. I buy stock in
Sure.
the generic company that makes nystatin now.
Yeah.
But
But I think, listening to you, I think rightly, we should all be good stewards of antibiotics. And certainly your colleagues in pediatrics have really been trying for decades to give antibiotics, I think, less. I think people hear that maybe, and it's a confusing topic, but we're talking about probably the most vulnerable patients, these brand newborns that may come into the world with group beta strep on board. That's why it's so serious. It's not like to treat or not to treat maybe an ear infection in a toddler, right? That's not a fair comparison.
Yeah.
And you shared earlier also some sort of larger numbers about percentages of children in the NICU with group beta strep, et cetera. Share that again.
So, boy, that's good. So what I would say is that about 43% of the babies that have early onset sepsis is going to be due to Group B strep.
Yeah.
The other large portion of that is going to be from E. coli.
E. coli.
Again, for the reasons that we talked about.
Yeah.
It's in the vaginal flora.
But almost half of the children who are sick from group beta strep.
Yeah. 3 organisms: Group B strep, E. coli, and Listeria. Listeria used to be a big one. It's why you tell your pregnant moms, don't drink unpasteurized milk. Don't eat deli.
In fairness, we don't say that too much anymore, but you
would
caught
say.
me. Yeah.
But no, you don't want to eat deli
Yeah.
meats. You don't want to eat your unpasteurized milk or those soft cheeses because they have the potential for harboring that bacterial Listeria. That is also a very, very serious sepsis. But we don't see that anymore because that's part of that general knowledge that you just don't do that when you're
Now,
pregnant.
I should know this number and I don't, but I'll put you on the spot. So if we wanted to say, okay, you are GBS positive mom, what's the likelihood that the child, I guess if we want to say would be GBS positive, or maybe we should say GBS ill, perhaps would be a better thing to say. What's that likelihood? Maybe high, medium, or low would be safe if we don't know an exact
For
number.
a mom that has...
No, so the mom's GBS positive, and she's thinking treat or don't treat. If she doesn't treat, what's the likelihood that her child is going to be affected in some way?
So it depends. It depends on how long the membranes were
Sure.
ruptured. It depends on whether mom got antibiotics for more than 4 hours prior
Yeah.
to delivery. Was it penicillin, ampicillin, or cefazolin? Um, what's the gestational age of the baby? All of those things go into the risk stratification,
Sure.
and they're things that we take into account. Kaiser Permanente developed a sepsis calculator that looked at tens of thousands of babies in their system and what the risks were associated with those specific factors, and developed a sepsis calculator that it's one of the mechanisms that we can use to determine whether or not a baby should, be observed in the NICU and on antibiotics, or are they okay, as long as
Yeah.
they're well appearing, to stay with mom.
Yeah.
And so that's one of, 3 different ways that we use to assess a baby's risk. And that they give that in terms of the risk per 1,000 live births.
Mm.
Just because your risk is 0.03
It's a small number.
doesn't mean that you're not going to fall into that 1 in
Yeah.
3,000 babies, 1 in 30,000 babies that might have, been septic.
Yeah. It's interesting. I mean, if group beta strep and E. coli went away, you would have a lot less work to do, wouldn't you?
No, we've got prematurity. Although those things do oftentimes, premature birth is oftentimes due to infection.
Oh,
So,
well, sure. Yeah. That's interesting. So we've talked a lot about the babies that are there from group beta strep, and we talked earlier a little bit about gestational age, 35 weeks, 36 weeks and 6 days, et cetera. Let's go all the way the other direction to a topic I know is difficult for neonatologists like you, and that is babies, as I said at the beginning, born at the edge of life. I remember when the edge of life was 28, 29 weeks. That's not true anymore. Explain that and what those numbers mean, and what is a survivable age for a baby in your estimation?
the babies that are delivering at 24 weeks have a very good chance at surviving.
Mm.
A lot of these babies will have some disabilities, difficulties, whether it be from something we call chronic lung disease or lung injury from using the lungs before they actually were fully developed.
Yeah.
They can have problems with their brain, whether it be from infection or inflammation or from bleeding.
Mhm.
All of those things can lead to long-term disability, lifelong disability. And so those are the things that we talk about with the families when we're counseling them about the risks of delivering a baby preterm.
Yeah.
And the American Academy of Pediatrics has said, babies that are born at 24 weeks or earlier, we really need to have an open discussion with the family about what those risks look like, not only of the chance of the baby surviving, which is fairly black and white, you either survive or you don't.
Yeah.
But if you do survive, what's the child going to look like when it's 5, when it's 10, when it's 20, when it's 30?
But 24 weeks is what the old 28 weeks used to be. So
Yeah.
thanks to people like you and research and technology, that number's moved down to 24. I'll push you. What happens at 23 and 23 and a half? How do you respond to those children?
So we talk with the family about those risks. And to be honest, even though we're talking to them about what those risks are, we're talking to them at a very vulnerable time. Typically, it's
right.
when the mom is coming into the hospital in preterm labor and they're facing the choice of, I'm going to deliver my baby, halfway through the pregnancy.
Mhm.
What does this look like? And telling them that their baby's got X percentage of chance of having severe or profound cerebral palsy, having a head bleed, an intracranial hemorrhage that could be severe enough that the baby dies just from the blood loss into the brain. Those are the things that we have to have a very serious conversation about the risks so the parents know what they're getting into and what it's going to look like after the baby delivers. But thinking beyond that and what that looks like, again, at a year, at 5 years, at 10 years, and adulthood for this future child, it's a real difficult concept for them to really crystallize and form. And what they want is they want to have that normal pregnancy back and have that healthy baby that was going to deliver at term.
Yeah.
And
I like the
they're
way you said
thrust
that.
in.
At a vulnerable time, it seems horribly unfair to ask a family to make such a critical decision in such a tough time. I've seen, several times when you and your colleagues will come and look at an extremely premature baby, and sort of assess things and maybe try to resuscitate a little. And then it seems like it can become pretty clear pretty quickly that this child's not going to survive. Let's change to comfort care. But it must be an incredibly difficult thing to do for you.
It's something that we're prepared to have that discussion, but it breaks our heart
Of
because
course.
we know that every one of these children that we're taking care of, whether they're, the size of this piece of paper in terms of length, and certainly not width, but or if they're a bigger child that just isn't doing well for any other number of reasons in the delivery room, and having to talk to the family, because this child represents what their dreams were for that child, and all the way up from the time that they found out that they were pregnant to the time that they found out they were delivering either a preterm baby or a baby with anomalies that might be life-threatening. All of these things are just mind-crushing, dream-crushing, and every family wants to hope for the best. And so we do our best to just present in as compassionate a way as possible the facts. This is where we are.
Well, I'm glad you and your colleagues are there, and that's tough. That's hard work, but so meaningful.
Yeah.
You mentioned as part of extreme prematurity, sort of quickly, brain bleeds. Talk more about that, and I want to connect that to a question that comes up for a lot of our patients, vitamin K, something that sounds so simple, but yet when you're talking about brain bleeds, not so simple at all. So go through that a bit, if you would.
Sure. So with regards to a term baby, there's a lot of data that's out there now for any number of reasons that whether it was a neurosurgery group that was looking at asymptomatic babies from the standpoint of, bleeding, but we're having head imaging done for another reason. They go back and look at that. There was one study that I looked at that said up to 40% of otherwise asymptomatic term infants.
Showing no signs of anything.
No signs of anything, having an MRI for a different reason or a head CT for a different reason, an ultrasound for a different reason, had some aspect of an intracranial hemorrhage. So a subarachnoid bleed, a subdural bleed, an intraventricular bleed, an intraparenchymal bleed. And vitamin K is one of those cofactors that helps the body's clotting system to work. And babies that, when they deliver, they are inherently vitamin K deficient. And so...
Because I understand it comes from the bacteria that live in their gut. They don't have a lot of bacteria in their gut until they've had a chance to acquire some bacteria, right?
Not a lot. Surprisingly, they do have some. They're swallowing it from the amniotic fluid, and some of it probably is crossing the placenta, but it's not enough to generate what they need. The problem is that, what we hear from parents that decline vitamin K is that babies survived for thousands of years without getting vitamin K. And my answer to them is that our infant mortality rate was much, much higher back then. And we have science that's shown us that we can do this to reduce that risk of a bleed that otherwise would remain asymptomatic because the clotting system is going to work. It's not going to exhaust the clotting factors that are working. And by giving vitamin K, you can help reduce that risk of that baby's otherwise asymptomatic bleed from becoming symptomatic or lethal.
I hear frequently that almost sounds like a design flaw. You mean babies are born inherently deficient in something that's so important they may bleed in their brain, and we're not going to have an answer to that question, at least not sitting here, are we?
Sitting here.
But nonetheless, it's rare for something to be serious, but yet when something happens, it can be devastating. Now, you were talking about the asymptomatic bleeds inside the brain, but the symptomatic ones can be truly devastating, can't they?
Yes, they can. They will oftentimes present as seizures, and the seizures can, be fairly subtle or they can be very dramatic. And any family that's had a child with a seizure, it's again one of those things that really just takes you from this, perfect place of just having had a baby to your life has changed. And what does this mean? Is my child going to have brain injury from this? Is it going to be lifelong? Is my child going to die from this?
Now, would that be shortly after birth, or could that be a delayed phenomenon?
Yes.
Oh, yeah, even more frightening, I guess, to a degree.
Yeah.
So if we ask the value question, is vitamin K worth it? I think you'd say absolutely.
Absolutely.
Is there a downside to giving the preservative-free vitamin K?
None that I can know of. I mean, certainly we've all tried to do our due diligence and read and
Yeah.
look into the risks associated with it. It's preservative free, so the risks that we used to have from injecting various types of preservatives into the baby,
Yeah.
they're not there.
I think sometimes it is confused with a vaccine, which is something that makes your immune system do something. The vitamin K is a nutritional supplement.
Yes.
The other question that I get commonly, I'll put you on the spot, is, okay, I understand the vitamin K. I don't want to give my newborn a shot. There's vitamin K drops available. I'll give them drops. And then my answer to them is, well, it sounds like a good idea, but just because I think it sounds like a good idea doesn't mean it is. I'm not aware of anybody studying that to prove that oral vitamin K is just as effective as the injection. You have any feelings about that?
Yeah, so oral vitamin K, while it may be effective for that later vitamin K need for those clotting factors, it's not going to be helpful in that early
For that
period where
immediate.
they're at risk for early hemorrhagic disease of the
see.
newborn.
Yeah.
And the vitamin K is really our best way to get it into the body, get it over to the liver, to the clotting factors, to help prevent, reduce the risk of this baby having severe bleeding.
Yeah. Wow, that's interesting. Well, I hope none of our viewers ever meet you.
Yeah,
And
out on the street.
maybe at the mall or
Yeah.
something. But if you had to speak to parents who have not had a NICU child, and you wanted to somehow prepare them for what to expect if you had a baby that needed to go to the NICU, what would you share with them?
I would start out with what's going to happen in the delivery room. If we know that the baby's going to need to be in the NICU because there's a problem with the way the lungs developed, with the way the heart developed,
Yeah.
or just because of extreme prematurity, we're going to be there in the delivery room with you, waiting for you to hand the baby off to us after delivery.
Yeah.
Ideally, we would be able to still do that delayed cord clamping that helps to increase the amount of red blood cells the baby's going to have, the amount of hemoglobin the baby's going to have, hopefully reduce the number of transfusions it may need while it's in the NICU, especially for those extremely preterm babies, stabilize their blood pressure so that there's less likelihood that there's other complications in that first few days of life.
Yeah.
After that, we will receive the baby, dry the baby, manage the airway, manage the circulation, make sure that the baby is transitioning well. So we talked about that transition period.
Yeah.
Make sure that it's going from relying on the placenta to get oxygen into it to being able to use the lungs to get oxygen in. So again, going back to supporting the airway and the breathing, and the circulation typically comes right after that.
Yeah. But in fairness, it is a scary place there where you work to walk in, not to you, but to the average person to just walk in. And what I've heard patients say that they remember the most, especially if they had a near-term child, when they walk into the NICU to be with their own child and they look around, they see those tiny, tiny children. And I think maybe they weren't prepared for what that was going to look like.
Sure. So we do. And when we know we're having a family that's coming to the NICU, we talk to them about what's going to happen after they leave the delivery room. The father oftentimes can come up with us. Mom obviously is captive audience down in labor and delivery for a while.
Yeah.
But we'll bring the baby up. Typically, it's going to be on a warmer if it's older, or if it's bigger and we need. If it's older and bigger, if it's smaller, it may still be on a warmer, or one that converts into an incubator or something, a contained environment, so that we can do procedures and then close it up and get it in there.
Yeah.
Nowadays, a lot of NICUs have gone to single patient rooms, and so having to see all the other families, and there is less of an exposure, but at the same time, there are monitors on the walls. There's monitors all down the hallways. There are sometimes families that you're going to hear that are, going through a very emotional period.
Yeah.
You'll run into them out in the waiting room or into the break room that the parents can go and relax in when they don't want to have to be listening to all of those monitors. They can go and prepare, a meal out in the dining area off of the NICU, sit there and relax, talk with other families. and then come back. There's drawbacks to both types of units. The
Yeah.
open unit where you've got 15, 20 babies or 100 babies, and an open unit, there's lots of noise. It's a lot of stimulation.
Right.
Not really good for the very small developing brain. As they get older and they get closer to term, they probably need that stimulation. And I suspect what we're going to find over time with more and more research is that there is going to become a period where our babies that are in their single patient rooms need to be moved into an area where there's a little bit more noise. And whether that means putting them into an open bay, which completely doesn't work for the family that's getting ready to go home after they've been in this single
Yeah.
room for 2 months, 3 months,
Yeah.
or more, that might actually be better from a developmental standpoint. But ultimately, the goal is to get the babies home as quickly as is safe, because home is the best place for
Yeah.
them to develop and for their brain to develop, not in a hospital, in an
Yeah.
institution.
Well, as we finish, I know people want me to ask you this, but you've been doing this a long time, and you treat babies who sometimes die. That's why they come to the intensive care unit. How do you keep going? I think my job is easy. How do you do that for 18 years? What gets you to come to work every day?
Not every day is like that, which is good.
Yeah.
There are obviously very heartbreaking moments, and there are some instances that I've seen through my career where a family is losing, their baby, their
Yeah.
dream, and the way that each family copes with that loss is different. And in some cases, it can be just incredibly warm, and for the amount of loss that's there, I would say just amazing how they celebrate that life.
Yeah.
And then other times it's just so unexpected that, it's devastating. Every loss is devastating to a family. It's devastating to the healthcare team.
But yet you come back.
We come back because we know that there's babies that we can help, and that without us, there would be more of those losses.
Yeah.
So just to take a step back to our extremely preterm babies, we talked about the limits of viability.
Yeah.
And while 24 weeks now is a threshold where I think most of us would really be uncomfortable not doing much,
Sure.
where is that gray area now? And certainly 23 weeks, I think, is becoming less gray. Most of us would be, comfortable working with a baby that's 23 weeks. As we get down lower than that, we get down to 22 weeks.
Right.
And we still want to offer care to those families if that is the choice, the path that they want to take.
Yeah.
The other option beyond being aggressive when you start getting into 23, 22, 21 weeks is to hold the baby and celebrate what this child's life, is right here.
Short,
just
but
the
here.
life itself.
Yeah.
But also, what he represented to the family.
Wow.
And doing that instead of going up to the NICU when the chances, certainly at 22 weeks, it's reasonable. Holding the baby and just loving it skin to skin while it's while it's short is there, and it's with the parents, as opposed to going up into the NICU, having IV started, lines started, tests done, labs drawn, medications given. And that is a very individual question for each family.
But it can be very beautiful. I've certainly had the chance to see that.
Yeah.
We've moved that number, though, as we said, from 30 to 28, now to 24, maybe 23. Is that the end? Or decades from now, when you and I are gone, will they be talking about 20-weekers and 19-weekers? Or is that our limit, do you think?
They talk about it. There's some research. I don't know how advanced it is in terms of liquid ventilation.
And the artificial placentas.
Yes. They're going to keep trying that until they can get to that point where, we can push that threshold further. But it's every week that you take down in the gestation, you have more and more factors that are pushing back against it, whether it's the skin permeability to, the environment, thermal regulation. Yes, we can put them in a temperature controlled,
Sure.
artificial amniotic fluid sac. Your risk of infection goes up. You
Yeah.
don't have the maternal, component that's helping to protect the baby anymore. And so there are all of those things. And what is that going to look like from a stimuli standpoint? How do you mimic the environment, the stimulation environment that's in the
Yeah.
uterus from the noises and the tactile stimulation, being able to push back and have resistance.
Yeah.
All of those things are unknowns right now. I'm sure they're going to do the research and look into it. I don't
Maybe our
suspect it'll be in
grandkids
my
will,
lifetime.
maybe mine and your grandchildren will look at this podcast decades from now and think, boy, those guys didn't know what they were talking about. They were so wrong.
Yeah, lots of bacteria.
Yeah. Well, thanks so much for the time. And of course, thanks for the amazing work that you and your colleagues do. But thanks for sharing all of this with us.
Yeah, you're welcome. Thank you for having me.
Well, I hope you've enjoyed this episode of All Things Women's Health as we talked about all things neonatology with Dr. James Cameron. I certainly enjoyed bringing it to you, and I'm so thankful for Dr. Cameron spending his time with us. I have to say that as I think about listening to Dr. Cameron, when he made the comment about life is life, whether it's the size of this notepad or the size of a full-term child that's born, life is life. And he talked about the hopes and the dreams of the parents for that child. And it struck me as powerfully that life is life, no matter how small, no matter how old or how young, that it's created in the image and likeness of our God. And it has a dignity, a human dignity, the dignity of the human person. And that can't be overlooked. At least it shouldn't be overlooked. I was also taken, as I think about it, as we discussed the limits of saving children at 24 weeks, at 23 weeks, now maybe even below that age. It can't go unnoticed to point out that in many states, California, Illinois, just to name a few, it's perfectly legal to intentionally destroy children through abortion at that same age. So isn't it unusual that Dr. Cameron is talking about saving children and all of the work and the technology and the energy that goes in to saving children at that age, and at the same time, one could intentionally destroy a child at that age? That seems worth some thought. Well, thank you again for joining us on All Things Women's Health. I hope you enjoyed the episode. I'd love to hear from you. What do you think about this topic? What do you think about the things that we've shared? Share in the comments. I'd love to hear them. I'd be happy to respond if you do. Are there other topics that you would like to hear about? I'd be happy to hear that as well and try to bring those in future episodes. I'll be back soon with another episode of All Things Women's Health.